تفضلي أستاذة.
شكرا دكتور هلال. بسم الله الرحمن الرحيم والسلام عليكم أجمعين. شكرا جزيلا لحضوركم جميعا، ونشكر بالذات الدكتور عمر مصطفى، ونرحب بأجمل ترحيب، ونشكره على حضوره وعلى وقته الثمين، ونشكره على انضمامه إلى اللجنة الاستشارية للمجلس الوطني. دكتور عمر مصطفى هو honorary clinical senior lecturer at King's College London, Associate Director of Medical Education, Associate Global Director for MENA Region RCP Global Royal College of Physicians London include health profession and digital health. شكرا دكتور عمر. ويعني أبدأ باختصار شديد. بعد ما حصل المجلس على ال WFME recognition WFME recognition، وبناء على توجيهات فريق ال WFME ولغرض قياس جودة عمل المجلس، أصبح لزاما أن نضع سياسة وإجراء لجودة عمل المجلس internal quality assurance. أرجو من حضرتك أن تعطينا فكرة عن هذا الموضوع. طبعا احنا بدينا نحط سياسات درافت. دكتور عبد العظيم مشكور، ولو كنت اتمنى يحضر بس عنده ظرف طارئ وما حضر. هو عضو لجنة استشارية وخبير بالجودة، هو كان مسؤول الجودة بالكلية الطب المستنصرية. قدم لنا مسودة مفصلة. دكتور فراس أيضا مشكور، قدم لنا مسودة عن الجودة. طبعا اطلع أعضاء المجلس على هاي المسودات، وستيل أنه نحن نحتاج أنه نسمع من حضرتك ونسمع من خبرتكم في هذا المجال. طبعا آخذين بنظر الاعتبار الإمكانيات. حضرتك يعني تعرف وضعية العراق ووضعية الكليات والمؤسسات. الإمكانيات محدودة بالنسبة للمجلس، وأتصور حتى بالنسبة يعني للوزارة. طبعا حتى تكون الصورة واضحة أمامك. المجلس يعمل تحت مظلة جهاز الإشراف قسم الاعتماد. دكتورة يسرى رئيسة قسم الاعتماد موجودة، أهلا وسهلا بها. ويعني يعني احنا نتمنى حضورها وتبقى ويانا على طول الخط، لأنه هم المعنيين بالدرجة الأولوية المجلس بهذا الموضوع. يتكون المجلس من 20 عضو. عندنا كادر وظيفي 2 بفول تايم، وعندنا 2 آخرين بارت تايم اللي هم من قسم الاعتماد، يعني سبورتينج لعمل المجلس. ممكن أنه القسم يرفدنا بموظفين من دائرة الجودة والاعتماد. يعني هاي الإمكانيات. يمكن دكتورة يسرى بعدين يعني تنطينا همنا ملاحظاتها القيمة، لأنه هذا عمل الجودة. فأنا من أقرأ عمل جدا جدا يعني هيوج، ويحتاج إلى كوادر، ويحتاج إلى يعني عمل مكتبي بالدرجة الأولى. دكتور عمر، الستيج is yours، وتتفضل إن شاء الله. شكرا جزيلا.
شكرا جزيلا، وتشرفنا بالدعوة. Okay, I'll start sharing. Okay. So I'm just trying to get my screen to share. There we go. Okay, okay, so you should be able to see my presentation. Throughout the presentation, I'll be referring to the NCAMC as the council, just for brevity. Okay, so I'm focusing on quality improvement. The concept of quality is a big concept. It has a lot of interactions with a number of interventions and approaches and programs. And the way I'm going to look at this is about definitions and how do you apply this. And of course, looking at quality, you'd want to look at this from a system level, but also from an individual level. However, micro. So you want to look at it from a macro and micro approach. And I'll try and touch on those points as an introduction. I'm sure there will be a lot of opportunities to discuss further. First of all, going through some definitions, I think is key to understand the differences amongst various definitions. So a standard is something that is either accepted as a norm or has been decided, or something that you'll find passed as a result of a law or a decree, or what people do. Clearly open to discussion. An audit is how the status quo is. Roughly, it's a statement of account. It comes from accountancy. Research is very different. It's about looking at new things, but systematically through investigation and inquiry. And so where do you fit quality and quality improvement in this? So quality is how excellent a thing is, whether it's subject, an object, all the way to a process and a system. And obviously an improvement is to try and make it better, as the name says. Which brings me into something that you may read and you may find. This is from healthcare and quality improvement in healthcare, but I'm sure it applies to a number of other domains, which is implementation and improvement science, which is a method to try and improve how we do things in quality improvement, but do it systematically so that you can generate outcomes, and the results the results generated could be rigorously evaluated. So you may see improvement science, implementation science, or now it's all lumped as improvement and implementation science. From a diagrammatic point of view, in some very simplistic terms, audit is where you start with. You start to look at how things are. Are we doing the right thing? Compare it to a standard. Hopefully simple and straightforward. In some audit methodologies, there'll be talk about closing the loop, audit loop cycles, and implementing change. That, I think, is still there. We're moving forward from that more into quality improvement. And as you can see, research is stretching the boundaries of what is possible to try and generate new things. Quality improvement sits in between. And of course, you have change against time, which is something I'll touch on later on. So how do you actually make things better, whether you do it systematically or you don't? Now, quite often people do things at the bottom parts of the cycle and get stuck in quality improvement over time and sustainability, which I'll speak about. Of course, whatever you do, whatever you improve, whatever you're trying to quality assure, you need to think about enablers and barriers, and I'm sure every project will have that. And that brings me to more concepts, more definitions, which is around design thinking and system thinking. This comes from also quality improvement, but applicable to many other domains. It comes from innovation, etc. So from a design thinking, you try and focus on the solutions. You try and get more down to the user level, or the micro level, where you're prioritizing these issues and aimed to get things better. When you're trying to think about a system, you're trying to think about bigger issues focused on the system. I usually view it as an ecosystem because everything is interlinked and interdependent. You try and focus on the problems, solving those, but at a system level. So I guess from where you are as a council, you need to think, how does that look like? Quality and quality assurance, quality improvement at a system level. Are there mechanisms there to allow you to do that, all the way from legislation, decrees, laws, etc., down to policies? And I've seen lots of the documentation already there on the website. And then trying to get into whether you or you're fostering that innovation or be a catalyst for that innovation to help medical schools and medical colleges into design thinking and start to create and cultivate that ethos and improvement movement and thinking. I like this chart because it comes from cardiac arrest world. And the reason it's called Østein is from a village in Norway where they had a meeting a long time ago. It talks about how the protocols, the science, and it's linked to survival from cardiac arrest. But of course, and it comes down to policies and how you implement those and what comes out of them. So you may have the better policy in the world, but without local implementation, zero local implementation or poor local implementation, the survival, which is the ultimate objective of cardiac arrest protocols, would be close to zero. So something to think about. Picked out from one of the intervention meetings the other day, which brings me to another concept from engineering. This is from resilience engineering. This is applicable to healthcare. That example I'm going to quote. It's about work as imagined versus work as done. A lot of the times when models and systems are created, we think that, well, whatever's written on the paper is actually what's going to be done, but quite often it is not. And therefore, looking at it, which comes back to what I was originally saying about design thinking and system thinking, is we need to think about both aspects when you're trying to introduce a new system and a new way of thinking, is how it's actually done, how can we improve that, but also how we imagine it should be done, so that we always stretch the new reality and try and improve things. This is a concept from the you see on the screen is from the clinical world, in particular from inpatient diabetes, where I do a lot of. So work as imagined versus work as done is something to bear in mind. Clearly, quality improvement, quality assurance, all these systems, why is it important now for the scene of medical education in Iraq? Of course, the WFME recognition earlier in the year is an important and a symbolic step in time for Iraq and Iraq medical education to move to the next phase. Let's call it medical education 2.0. It's a unique national opportunity for coordinated improvement and innovation. It should not be treated as a tick box exercise, because by the time the WFME comes back, looking at the standards and how things are done, they will be looking at things at a system level and at a micro level from inspection point of view. So this is an opportunity for the council, I think, to encourage countrywide and individual excellence, however that's done, whether by facilitation, encouragement, collaboration, bringing people together, or perhaps for the initial prototypes for things to be done at a smaller scale and then scaled up. And the science and evidence in MedEd, as in any science, evolve all the time. So we're not going to stay here. So by the next, in 10 years' time, evidence would have changed, things have improved. So we need to be able to demonstrate progression. The growth of medical schools in Iraq, as you all know, has been very different in the last 40 years, and certainly since in the last few years. There's a lot of medical schools. How do you ensure quality of the output is going to be key. This is slightly old data, and of course those trajectories are up, even compared to 2020 when this slide was originally, or 2018 when this slide was originally prepared. Curricula evolves over time and how things are done. This is a demonstration of the curricula in Iraq all the way from 1927 to 2020 when this slide was prepared. And you can see that, again, things evolve all the time, and it's clearly we need to be able to move with time, but also with international literature and the latest evidence from around the world. This is, again, how things are evolving from a broad perspective in medical education, moving away from individual disciplines to, again, looking at things at health system, teamwork, focus on learning rather than just knowledge acquisition. So there's a lot to think about in here, but I think starting somewhere would be important. And again, we need to think about improvement versus transformation. There's a lot of pieces of work happening across the country. How do you encourage those? How do you cultivate innovation? How do you foster that and improve it, whilst at the same time maintaining quality and making any change evidence-based so that it can move forward? This is an example of transformation of medical education. At the bottom, of course, is how do you make sure that not just doctors work together, but how do they work within teams? And that's the current thinking, is looking at things at a system level, but also as teamwork. And in very simplistic terms, there's what it comes down to. Maintaining quality and catalyzing change, you'll need standards, you need a method, you need the right environment, the resources, the networks behind that. I'll go through some of the micro parts of quality improvement and what that means in medical education. So the standards are here. I read the 2018 standards and I saw the website, which is great. It's evolving all the time, and of course the WFME has their quality improvement standards, and they quote in it that they are guidelines, that if there are better standards applicable elsewhere within the country, then there is no need to invent new ones. It's just a matter of assessing those and taking what's written, I'm talking about the WFME, as principles. And the most focus, of course, now is on outcomes. Clearly, you want to look at the process, but outcomes are key in here. That's from the WFME document, which mirrors what's in the Council's document as well. I'll touch on the QI method. What I'm going to quote is a method. There are a number of methods which you may read. There's the model for improvement. There is lean. There's total quality management. There is Six Sigma. There's loads of others. They all stem from the humble PDSA cycle, which historically came from industry and evolved to be adapted to medical care, healthcare, education, and a number of other places. So I'll focus on the model for improvement, which is, as you can see on the screen, evolved early in the 90s, comes from the Institute of Health Improvement in the United States. There have been many iterations of that, and it focuses on key things. How do you set your aims, establishing the measures, what are you going to change, testing the change, implementing and spreading. And the PDSA cycle at the heart of that is key to its success, is how you put through the changes, the thoughts, the prototyping, creating the change, testing the change, and then moving it up into the cycle. And that cycle is a spiral of change and to advance things forward. I'll use an example in a minute to just demonstrate something that may be of interest. Those are the Council's vision, mission, and objectives, and clearly quality is very at the heart of this. And how do you make sure you not only maintain the standards, but how do you improve that standards over time. So there are different phases in there. I think the key step is to get the standards right, which you can see is you have the documentation and you have the recognition. So that's great. That's a first step. Second step is to how do you know what's going on around the country, the standards. For example, this may be available from the inspection data as the accreditation of medical schools evolves and develops all the way to accrediting all medical schools. And then, of course, the next step is trying to push the boundaries. Well, how do we make things better? How do we learn from each other? And I'll use one example in here. Clearly, as a council, going back to system thinking and design thinking, need to establish where you sit. That's from the website is the organogram of where the council sits and its relationship with the various bodies within Iraq. Clearly, it's not a regulator for doctor because that's what the Iraqi Medical Association is. You could be, and you are in a position to standard sets as part of the document. Commissioning, that's difficult. You within your role as council, the commissioning part potentially could be how to make sure that medical schools get accredited. How do you improve the quality? But commissioning goes well beyond this, so that's perhaps more to do with the Ministry of Education, higher education, and how they commission medical schools, etc. So ensuring quality is well within what you do. Delivery and innovation, enabling and convener could potentially parts of what the council could do in bringing people together and fostering that innovation, but actually the actual doing of the quality improvement, recording and doing things, it sits within the medical schools and however they want to engage. So the message really needs to be clear that the standards are there, the quality is, how do you ensure the quality, how do you do the measures, is something that sits between the council and the individual medical colleges. I picked up one standard from the document, from the 2018 document. So, for example, teacher and student feedback. And it says the medical college must systematically seek and analyze and respond to teacher and student feedback. And it's very nicely laid out. You have a quality development standard as an audit standard. Is how do you use it for program development? Great, really well thought out, put in there. Questions to answer really. Well, you may have medical schools who are either not doing that, all the way to medical schools and colleges doing that and using it for program development. If I give an example from elsewhere, so where I practice, there are quarterly surveys being sent to medical students as they finish their blocks, for example. And that feedback forms part of the block development about teaching, learning experience, how they felt, how the students felt things were done. And then that acts as a single point in an annual feedback. So you'll have, let's say if you have 4 or 5 blocks in the year, you'll have 4 data points of quality. Then you have an annual survey where you can pull that together with all students everywhere, multiple sites, for example, etc. So that's the scale of how that could go. Could be a very small, but also needs to be part of a bigger system to look at the whole thing in the medical school. Now, historically, in many places, this was done on paper. Increasingly, this needs to be done digitally on survey tools that are, some of them are freely available, some of them requires a fee, and there are many other ways. So some of the things to consider: timings, as I said, it needs to be thought about of how you do that. What themes are you going to do? What are you expecting to think about? So you need to think, well, what is the curriculum? What are they being taught? What's the setup of the education? It could be depending on the courses in the medical college, etc. And how you use the data is going to be the key thing. The phrase I often use is, well, we collect a lot of data points, but they sit in servers generating heat or papers cluttering the office. And it is key to use those data to generate action, either locally at medical colleges level, but also nationally, if you're thinking about collating those and publishing this for the benefit of colleagues around the country and as means of improvement. And you may find other things not noticeable in other countries, for example, and it will be interest for international literature. And that brings me to information silos. Now, there may be already a lot of data being collected here and there in different medical colleges. It's clearly important to pool that so that if you want to think about a country, you have a whole country data pools in front of you being done individually. So as a concept of quality assurance, that's what you want to look at. In some countries, they do this nationally over in a set period of time where they do this, and then they generate a national picture of medical education, something to be aware of. Going back to data points, what I've illustrated earlier is there's a lot of data points. The key in how you link them and how you generate that insight in order to generate that impact. I'll come to that example which I've demonstrated. So from what we're trying to achieve with this example is really around auditing and quality improvement to start with. Because if it doesn't exist, or if it exists but it's not harmonized or not done systematically, then you'd want to think about an audit quality improvement type project to drive it forward. Your next steps is perhaps research and how you move it forward to try and generate something new. But my example is going to focus on quality and how do you generate that quality from the system. Of course, thinking about it in a smart way is important, and how you choose things that are achievable. As doctors, we're trying to do a lot everywhere, maybe not realistic. So scaling things and scoping that to something very achievable in a time-bound manner is important. I'll come to that in my example. So how do you set aims in this particular thing? So for example, in our example, I went for, the standard said, well, you have to have data from students and teachers to inform program development. I went for, well, this medical school has nothing. No, there's no data. So how do you establish a standard set of questions for student feedback in 12 months? Now, you could argue that this is not very specific either. So perhaps thinking about it in a very small thing for a specific module, and then use that as your prototype to expand further. 12 months is a time limit so that it can be planned and project managed very well. I'll apply that to the model for improvement. So we got our aim. We think it's okay. It needs a bit of work, but let's assume this is fine. Establishing measures is key. Quite often in quality improvement, we set a lot of aims. We start going to the project, but actually we don't know what we're measuring. How do we measure quality is key. So it could be as simple as the percentage adopted by medical colleges, how many adopted it, how many departments are using it if you're on a single medical school, how people interact with it. But for the purpose of this, I chose percentage adopted by medical colleges in a single module. The developmental question is the change. Now, clearly starting from, I'll demonstrate that on individual PDSA cycles, starts from series of events. So the PDSA cycles, which comes from Plan, Do, Study, Act, PDSA cycle 1 could actually just to know how many are using it. Now, if the intention is to do it for a single medical school, then actually that could be within a medical school for a single module, and how many modules, for example. Make sure you have a standard set of questions rather than questions that come from nowhere or randomly. It needs to be based on a systematic method of setting questions, and there are ways to do that, for example. And then you implement it, choose a set of sites or a set of modules within a single medical college, and then you scale it up. Quite often change happens at a bigger scale. I think setting intentions at bigger scale is good. Implementing stepwise and a step-by-step is key for success. And then evaluation is going to be important to uptake and look at barriers. So that could be, for example, your PDSA 4. And as things move forward, start to get the insight and the knowledge. And that's where, for example, this could form part of a paper for council to look at and approve and move forward, as an example of looking at quality and quality assurance. Publications are key because we can cite them around the world. So it's an opportunity for everyone to get involved. In terms of the measures, if we break it down to simplistic terms, there's always a process and outcomes. There's a balance between measuring a process and outcome, so that your measures could actually include both. Balancing measures is something that comes from a clinical world. So for example, if you implement a project to look at clinic attendance and you improve that by introducing a change, let's say by sending a text message to a clinic list, people on a clinic list, and they all turn up, that may lead to a lot of disruption in how the clinical care is delivered. So balancing measures is to try and think about what would happen as a result of the change. And how do you counteract that? Something to consider. This is called a run chart, as how the data are plotted. So, and going back to how I chose the percentage of medical colleges participating in this. So this measures value being measured against time. As I stated earlier, 12 months is when the project ends. You have sustainability. I'll go to sustainability in a minute. Let's say you're measuring medical colleges here, and you can start to see that by the individual months, number of medical colleges are enrolling. It automatically calculates the median, and you can set the goal of however you want that. And then by the end of the project, you have 8 or 9 medical colleges enrolled. Great. Against the total of, let's say, with the ones you've accredited, 15. So that's 50% in enrollment. Great. That moves forward. But then looking afterwards, things get improved and people think, okay, well, we are on the right path. And then sustainability is key. Then things start to drop. That's as important as the design, is making sure things are sustainable and continuing, because there might be other barriers that haven't been factored in. So again, who's going to look at this, who's going to develop that, needs to factor in a value as well as sustainability. And with each successful change or implementation, there's an opportunity to replicate the change, the same unit, other units, wider learning, and wider publications. I would also add in here learning from things that did not go to plan. We always aim for things to be successful, which is great, but many barriers are there. Sometimes things don't work. So it's important to learn from things that are not going to plan. So that's what it looks like from a model for improvement, potentially for a project that could be developed in there. The environment, the resources, bringing people together is going to be key. I think the scene is well set with the presence of the council, the guidance, the recognition. So it is the perfect opportunity to catalyze that change and to maintain the quality, which brings me to the concept of communities of practice. Now, as council, you will be leads in this. So you could be leading the way in bringing people together. So that could form the opportunity for meetings, updates, networks, however you want to catalyze change. Because there will be people interested who will be looking at particular things, so they may choose to be leading as a group from within council and the wider network within the country to work together towards a common goal using whatever resources available. So something to bear in mind in there. Bringing the whole thing together, you would want at the standard where we're starting, but over the cycle of recognition, which is 10 years, and over the cycle of the individual medical colleges, the standards at best maintained, at minimum maintained, but clearly over time, these standards need to evolve. And mapped against continuous quality improvement, the evidence that gets generated from learning experience, curriculum design, implementation, competencies development, assessments, and faculty development. Sorry. And that mapped against national graduate outcomes, health overall, aiming for higher, healthier population and high quality of care. So that brings the whole picture together, and hopefully that gives you an idea what that system could potentially look like. So quality is key in maintaining the momentum for accreditation. The recognition by WFME is a milestone in the history of medical education in Iraq, adding to other milestones. Standardized methodology and approach is key. Focus on outcomes is important. Change doesn't have to start big, it can start small, but with the right standards and the right system approach is going to generate gains. Value-based care and sustainability is going to be key to this, because a change that lasts for a year is good for the time being, but may not be good for the future. So it needs to keep evolving and sustained. That's all I have. I'm happy to take questions. Thank you.
شكرا دكتور عمر على هذا التقديم الموجز وال concentrated presentation. It is a good start for the NCAMC to start the quality improvement activities with such an introductory lecture. Still, we have many items or parameters to be assessed for quality. And each item is need a huge activities, a huge efforts. So what do you advise? How to start? When to start?
Thank you. I think the important thing is to establish who's going to do what when. You have the standards. So let's take, for example, the standards you have already. There are different sections. So for example, curriculum, learning experience, assessment. That could be led by someone from council, and bring the group together from around the country to start to collect the data points and start to see where things are. So a series of mini quality improvement projects is, I think, is the way forward, rather than trying to do everything together as a bigger group. Small steps is key.
Yes, exactly. We have to start with the small steps. So if we review the standards and try to improve the quality of the standards, does this mean updating the standards?
Well, that's always going to be on the cards. I think the updating the standards is going to be a much bigger step, and it will rely on either evolving needs within the country and or evolving international standards. These standards say usually, if we think about similar standards around the world, they evolve over period of time. So that could be 10 years, for example. So that it may not need that. But of course, if during the review process, someone's and a group of people go, well, actually, this doesn't make sense, or this needs updating, it may need minor updates along the way. But an overall reviews tend to happen across milestones. So that's usually, I mean, I wouldn't put a number, but usually 10 years if we think about a curriculum, for example.
Yes. Thank you. Dr. Hilali, please.
شكرا جزيلا دكتور عمر على التقديم الرائع حقيقة. في بعض الأحيان يستخدمون مصطلح it is like a music to my ear. دائما عمر يتحفنا بالبرزنتيشن مالته بالنتورك. طبعا هو الهيد مالتي، يعني المدير مالتي بالنتورك، بالار سي بي نتورك. ففعلا دائما استمتع حقيقة بالبرزنتيشن مالته، كلش مركز، كلش اب فوكس، وكلش اب تو ذا بوينت. عمر ابد ما عنده اكسسيف يعني خلينا نقول اكسبلانيشنز وتوسع، لا دايركتلي يروح على البوينت. بس اني ممكن يعني excuse my ignorance خصوصا بالكواليتي اشورنس والكواليتي امبروفمنت. بس راح اسال السؤال التالي واللي دا افكر به. اللي تكلمت حضرتك واللي قدمته انه كيف المجلس يعمل على تحسين الكواليتي بالكليات الطب، وهذا المشروع اللي قلته واحد من المشاريع المهمة جدا اللي الان نعمل عليه احنا بالنتورك، انه احنا نسوي ستاديز بالميديكال اديوكيشن والكواليتي امبروفمنت بالعراق قليلة وقليلة جدا if ever. بس اكو كونسبت ثاني، انه كيف المجلس يسوي internal quality assurance لعمله. لأنه يعني هسه أنا قدامي صورتين. الصورة الأولى اللي هو المجلس عنده policies، عنده standards، عنده procedures، عنده members، عنده activities. فلازم أكو internal quality assurance لهذا المجلس حتى يكون بالمستوى اللي خلينا نقول the minimally accepted by international bodies. وبعدين اكو شيء ثاني اللي حضرتك اتطرقت له الان اللي هي elegant brilliant، انه شلون ينعكس عمل المجلس اللي هو اصبح كواليتي بتحسين اداء كليات الطب بالعراق. خلينا نكون صريحين، واعتقد ان دائما الصراحه هي الطريق الوحيد للوصول للهدف. هوايه من الكلام يقول قسم من كليات الطب قد تاخذ اعتماد مشروط conditioned، قد تاخذ full accreditation، لكن انت من تروح الواقع الحال تقول كيف هاي الكليه اخذت هذا الاكريديتيشن، ومدى اشوف اني evidence انه اكو كواليتي في هاي الكليه بحيث تعتمد. وسمعناها من اكثر من مكان. وبالحقيقه البوينت اللي قلتها حضرتك اكو things on paper but they are not on ground، اللي هي بالميديكال education يعني تعرف بالبلاند كوريكولم والامبلمنتد كوريكولم. تجي على الورق اكو a lot of things على الورق، لكن من تجي على ارض الواقع ما راح تشوف هاي reflected at least to the same magnitude مثل ما موجودة على الورق. وطبعا هذه تعتمد على كفاءة الناشونال أسسر في التحقق من أنه what is written on paper is there on ground. فيعني أنا أريد أثير النقاش في هذا الموضوع عمر، أريد أفكار في هذا الموضوع، لأن إحنا مطالبين بالكواليتي internal quality improvement للمجلس. وأثناء زيارة الوثمي إن بالحقيقة رأسا قالوا أنتم عندكم quality improvement process في داخل المجلس، عندكم quality assurance داخل المجلس كمجلس، كآليات، كأشخاص، كعمل، قبل ما تنعكس على كليات الطب. وآسف للإطالة.
شكرا. quality assurance داخل المجلس حال أي quality assurance في المؤسسات تعتمد على again standard operating procedures and the how things are done. إذا الابروتش اللي عادة ينخذ هو إذا ما حد يعرف من خارج المجلس يجي يسوي inspection, they have to be able to trace back all the steps of decision making backwards from that decision. يعني مثلا إذا تشوف الليستة مع WFME standards for accreditation of the council, they will go through it one by one. هل في processes procedures؟ نعم أو لا. هل في كذا؟ هل في adequately trained trainers, assessors? How do you assure that? So it starts from standards, standard operating procedures, practices, and decisions. And then you reverse backwards. That process, those 4 layers need to be done seamlessly and transparently for every single decision, so you can actually trace these things, and it needs to be documented somewhere, because as auditors, as a committee coming from elsewhere, they will be looking at these things. So I think it needs ongoing continuous process of documentation, but actually need to start from scratch. And I think there's quite a lot, you wouldn't get accreditation and recognition as a council without having the minimum set, I would say. And then it needs to be developed. So standards, SOPs, processes, and decisions.
Okay, Dr. Firas, please.
نعم. أولا شكرا جزيلا دكتور عمر على التقديم حضرتك. حقيقة we've set a draft of quality assurance system for the council. وأعتقد هو has been read by the council members. فأنا أسأل حضرتك، هو حقيقة احنا معتمدين على بالدرافت صارت بهذا السيستم اللي هو تنبع من عنده بوليسي ويعتمد على simple strategic plan for the council. يعتمد اولا مثل ما قلت البيلر الاول هو الدوكيومنتيشن، اللي هو مثل ما ذكرت حضرتك اللي هو يشمل اكيد وجود ستاندرد ووجود جايد لاينز تنظم العمل مالتنا والبروسيسز والهاي. البيلر الثاني هو المانجمنت اوف ذس سيستم by whom it will be done, the resources management, the service provided for the college, whether as accreditation site visit, as workshops and any other activities, and monitoring, measurement, analysis of these data for finalization. This is simply the draft system we have written for the work of the council as a start, and there is a policy and some procedures to implement it, and with a simple, clear strategic plan for the next 5 years. For your kind opinion, and we can send you the draft if you can.
Yeah, please.
If you have time to read it.
Good plan. Please do. ابعث لي اياها، انا حاضر.
ان شاء الله. شكرا جزيلا حضرتك. في الريفيو يصير مجال
اي وقت.
شكرا جزيلا.
شكرا دكتور فراس. دكتور فراس يعني موسوعي في معلوماته، دائما يكحفنا بالدرافتس ويبذل جهود طبعا قيمة في عمل المجلس. نحن هسه حاليا موضوع جهود، اتخيل نفسنا اول من بدينا بالاكريديتيشن، بدينا نقرا الستاندردز وبدينا نعلم نفسنا ونهضم الموضوع، فنحتاج وقت الى ان نهضم موضوع الجوده ان شاء الله بوجود الخبراء وبوجود يعني تعاون الجميع. دكتوره آمال بليز.
Thank you. السلام عليكم جميعا، وشكرا جزيلا للأستاذ عمر. حقيقة presentation very focused, clear, interesting. Thank you very much. I have an idea, and I think your presentation make it even stronger in my mind. That's to say, the process of quality improvement can be related to one of the accreditation sub-areas. That's to say area 4, which is program monitoring and evaluation. And you talked about continuous processes, and this is the part of monitoring. And we have another part, which is the periodic evaluation. So principally, this is very helpful for us to think about the internal quality improvement or quality improvement in general. That's to say, what is related to the medical colleges in Iraq. So we have to make use of this area with its sub-area, I mean, with its standards, and we even can make use of the evidence generation details that have been written by the council. You mentioned that some of the processes need to be continuous and some of the activities need to be periodic and may take longer periods. So this will be helpful for us to follow the colleges if we want to make sure that they have changed and they have improved medical education. And we can even make use of it for our own activities to see and to follow some of the activities of the council on continuous basis and to plan for evaluating other activities of the council periodically. You mentioned the development of the standards, accreditation standards, and you took the curriculum as an example, and you mentioned that this is the standards. If we want to develop or change the standards, we may think about 10 years, which is very nice. I like it very much. This is not something to be changed on yearly basis or even 2-3 years. 10 years is very rational if we want to evaluate the standards and create any change, of course, as you said, according to national or international purposes. Still, I need your opinion, please, in this regard. If you have looked thoroughly on Area 4, if we can make use of the standards and of the evidence to be generated in this regard. And thank you very much.
Thank you. Area 4, remind me, is, I don't think I have the document. Well, evidence generation, as you say, is continuous. So you need to think about what you're trying to achieve. Again, it's a small piece. You start from small, you start to make it bigger. Standard setting encapsulates a huge amount of work generated from the evidence that you see on day to day, because the standard for set internationally will be, for example, different if you set it in Iraq, because the conditions in Iraq are different. However, it should not compromise quality. So you may want to think about setting a standard because you have specific population needs, and that's the basis, for example, of the WFO, who said, well, actually, these are guidelines, but don't compromise on quality and outcomes. But you may have to set something interim, temporary, until you get to the standard, but make sure that whatever standard you have doesn't compromise quality and patient outcomes, because ultimately that's what we're trying to do. By the way, 10 years, I think we're already halfway through anyway, so it will take probably about two years to generate the next set of standards anyway. So 2026 is the time to start.
Inshallah. Shukran.
I شكرا دكتورة آمال, شكرا دكتورة Omar. I don't think that we have to start in 2026. Because we have to start earlier and to finish at 2026.
Takes time.
Yes, according to the policy of NCAMC, we have to reset the standards or at least update it every 6 years, according to the policy of NCAMC. شكرا. دكتور محمد, please.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
Thank you very much, Dr. Omar, for this focused presentations and system-based thinking for this quality improvement. الحقيقة يعني أنت وضعت على عاتق المجلس مهمة أخرى وكبيرة يعني، وهي موضوع quality improvement للكليات. احنا بصراحة يعني عندنا ديوتي كلش كبير انه يعني we accredit the college، نقرا الدوكيومنت مالتهم، راجعها، يعني العمل طويل وكثير وكليات كثيره والحمد لله والشكر بدات تقدم. فاما احنا نجي نسوي كواليتي امبروفمنت الكليات، اعتقد يعني كلش يعني خارج قابلياتنا، احنا كلنا عندنا ديوتيز يعني. واما الكبار هم المتقاعدين يعني الله يحفظهم ان شاء الله، هم اكيد يعني
متقاعدين. شو بيهم متقاعدين؟
لا والله ورث المتقاعد الله يخليهم، بس هو قصدي يعني هم عندهم مسؤوليات
والله.
فيعني انا اعتقد يعني احنا كمجلس احنا ويانا ذراع الناشونال اسيسرز اللي هم they go to the college and they do site visit or they report to us. وعندنا يعني الناس اللي هم بالكليات يشتغلون بالاكريتيشنز، هذول خلينا نقول احنا يعني بني واحد. احنا نفسنا نحتاج لنا يعني احنا كواليتي امبروفمنت، نحتاج نطور نفسنا يعني بصراحه يعني. مثلا انا اعطيك مثال، مثلا احنا يقين هذا فشيء هو واقعي ومنطقي، انه احيانا بعض الستاندرد اكو انكونسستنسي بقراراتنا يعني. مثلا انا اقول هذا ما موجود، واحد من اخواني اللي وياي شو اسمه يقول موجود، وطبعا هاي مشكله كبيره يعني. هي يعني مشكله كبيره من هو يقول موجود انا اقول ما موجود. احنا صح طبعا راح يصير ديسكشن ويصير شو اسمه، لكنه هذا بصراحه يراد له علاج. طبعا احنا المجلس بدا بعلاج الشغلات، انه تعال اي واحد يكتب جاستيفيكيشن، انت ليش تقول موجود وانت ليش تقول ما موجود، وبعدين من يصير ديسكشن، وبعدين هواي خطوات. احنا بصراحه سوينا المجلس هواي خطوات مال كواليتي امبروفمنت سوى، مثلا هي جاستيفيكيشن. بعدين سوينا شغله انه مثلا هاي الاريا، خلينا نقول اريا اسسمنت، دكتور عادل الله يجزيه بالخير هو رئيسه واحنا وياه، احنا نسوي ميتنج الون، نقعد نجتمع ونتفق بيناتنا اذا مختلفين، يصير كونسستنسي بيناتنا، بعدين نقدم المجلس قرارنا والجستيفيكيشن مالتنا، نقدمه تقريبا شبه موحد. قد تبقى نقاط مختلفه وانا اعتبرها هاي كواليتي امبروفمنت يعني مثل جستيفيكيشن. بس احنا لا زلت، وتذكرت الفيدباك، لا زال عندنا مشكله بالفيدباك يعني على عده مستويات. يعني مثلا من يقول بالاسسمنت انه الكليه لازم تعطي فيدباك للطلاب، يعني سواء فورماتيف اسسمنت لازم الكليه تعطي فيدباك، او سمتيف اسسمنت تعطي فيدباك للطلاب. تشوف هنا اكو مس اندرستاندينج، الكل يتصور انه الفيدباك should be taken from the student. لا يعني وهنا نقع بعده مكانات انه they misunderstood this، وهوايه كثيرا الستاندرد misunderstood. واعتقد يعني ذني يعني best understanding او understanding الستاندرد يعني by all those people اللي هو احنا والناشونال اسيسرز والعاملين بالكليات. اعتقد هذا يعني له برايورتي يعني، لانه اذا فهمها قدر يطبقها صحيح وقدر يشتغل عليها صحيح، واذا ما فهمها وما عرفها ما راح يقدر يطبقها صحيح، ما راح يقدم الدوكيومنت الصحيح. يجوز هو عنده بس هو ما مفتهمه، يقدم دوكيومنت مختلفه يعني. فبصراحه يعني المجلس عبر هالسنوات يعني يقدر يكتب على الكواليتي امبروفمنت الاشياء سواها. طبعا ربما ماكو ميجرمنت واضح، بس هو شغل سواه اللي هو ممكن ينكتب وممكن يصير ببليكيشن به يعني كارتكل يعني شو اسمه، ما بي ميجرمنت صحيح، بس هوايه كواليتي امبروفمنت بروجكت سواه المجلس، ومشكورين كلهم السيد الرئيس والسيد النائب وكل الاخوان. وشكرا جزيلا حضرتك على this presentation، وشكرا لكل من ساهم بالمناسبه يعني هواي اشتغلت على كواليتي امبروفمنت بالصحه، واخذت كورسات اونلاين من باث يونيفرستي على الهيلث كواليتي، لانه بصراحه انا ولا اطيل عليكم يعني يعني احنا عندنا علاقه ويا جامعه ليستر وزرناهم عده مرات. 2019 لقينا they changed the curriculum، خلي شهر كامل يعني الكواليتي امبروفمنت، يعني الاندر جراجويت يعني، وصار عندنا اهتمام بالموضوع وادركنا وحتى اشتغلنا بالصحه يعني على الكواليتي امبروفمنت. لو شفنا انه يعني مثل مع الطبيب لازم عنده سكيلز مع الدايجنوزز والتريتمنت ومانجمنت وانتربريتيشن انفستيجيشنز وكذا كذا، لازم عنده سكيلز مع الكواليتي امبروفمنت، لان الكير بالعراق يحتاج هوايه كواليتي امبروفمنت، يحتاج هوايه يحتاج اوديت يعني. واحنا شفنا الاوديت اللي سويناه ويا البوست جراجويت ايش قد كان امباكت بي على الكير مال شو اسمه. وانا شكرا واسف على الاطاله.
شكرا جزيلا. النقطة الرئيسية كمثل يعني of quality improvement looking to the future انه الكليات اللي هسه اخذوا accreditation it's like planning for an Olympics. You need to plan for the next Olympics, next accreditation, the moment you get the accreditation. That's the biggest quality improvement for each individual medical school, for each medical college, because by the time you get to the next time point for accreditation, you needed to start preparing and thinking about the standards and the processes. So actually, it's not a single data point, it is a continuous data point, and yeah, it builds on a wealth of efforts and all the way from council down to individual medical colleges.
شكرا دكتور عمر. يعني تعقيب على كلام الدكتور محمد، احنا نحتاج الكواليتي امبروفمنت مالت الكليات لسبب لازم شلون نقيس الاوتكمز مال شغل الكونسل او تاثير الاعتماد على الكليات. اذا ما نقيس الكواليتي امبروفمنت، شنو اللي اثر عمليه الاعتماد على نوعيه الكوريكولم، على نوعيه الميديكال اديوكيشن بالكليه، هل صار امبروفمنت؟ يعني اتصور هو هذا، يعني هذا جزء من الكواليتي اللي لازم احنا ناخذها بنظر الاعتبار. واعتقد WFME طلبت من عندنا بالبروجرس ريبورت مالتها how do you evaluate your outcome، فجزء منها نشوف improvement in the medical education of colleges. شنو رايك دكتور؟
استاذ عفوا قبل ما يجي ابو عمر، البروجرس ريبورت اللي احنا بالبلان دكتور عمر، احنا عندنا كل every 2 years progress report. يعني it listed what are the area or sub area did it achieve a full acceptance, partial acceptance or not accepted, and then within 2 years the medical school have to apply a new report which was called the progress report, from the 0 point after 2 years what happened, and then after 4 years before reaching to the 6 years, which is the time scale of the accreditation process for 6 years. So these progress reports are measurements of the impact of the accreditation on the medical school. And even we are planning inshallah for more workshops, and we صار نقاش على conference highlighting these issues probably in early 2025 إن شاء الله.
شكرا دكتور هلال. يعني أنا دا أقصد WFME تطلب من المجلس أنهم تقدم progress report، فهذا جزء من واحدة من الأسئلة اللي يريدوها من عندنا، شلون نقيس الإمباكت of the accreditation on the medical education in colleges. أكو أي تعقيب دكتور؟
Yeah, I mean, you can measure the impact of accreditation in varieties of ways. I mean, to start with, as Hilal was saying about, are they actually bound to any of the standards? Has that led to any change in the way they do things as per your standards? That's the first key step before thinking about developing and introducing new things. If the basic standards are not met, you can't really start to look at bigger picture and improve individual things. There will be pockets of good improvement and good change, but this needs to be presented and shared so that you can actually collate that as part of a national picture, but always start from a smaller individual medical college level. I would say start from basics. Are the basics being met, and then move up.
بس أنا واحدة من الجمل اللي سمعتها من إحدى الكليات من يشتغلون بالساس ريبورت، جملة كلش عجبتني. قالوا أنه هذه accreditation process أو الساس study لازم تكون منهج حياة بالكلية، مو مجرد يخلص هذا الساس وخلصت السايد فيزيت انتهى الموضوع. لازم يكون هذا منهاج حياة للكلية أو منهاج عمل للكلية.
Yeah.
نعم.
It needs to be part of every. لازم تكون نقطة بنقاش في كل اجتماع مجلس كلية، اجتماع المجلس التعليم الطبي، الأشياء اللي تنعمل. فهاي تعمل data points، و data points to be collated، لأنه إذا تسويها فجأة تصير صعب إنه تجمعين الداتا بوينتس، وصعب إنه تكون كمنهاج في العمل اليومي.
نعم، لازم يكون أكو فد قناعة، يعني هاي القناعة building up أو satisfaction يحتاج له يعني سنوات من العمل حتى تصير هذا satisfaction. من صارت القناعة هذا العمل راح يستمر.
It's a change of culture.
نعم. Any other question please?
احنا بحاجة إلى صورة، لأن هذه جزء من توثيق نشاطات المجلس بالكواليتي امبروفمنت. يعني هذه المحاضرة اليوم هي ضمن هذا السياق. فالإخوان إذا ممكن يفتحون الكاميرات ناخذ صورة، وهاي الصورة راح تكون للتوثيق حقيقة للمستقبل.
يعني واللابس دشداشه شلون يعني؟
يطلع بس راسه العرقتين وراسه والعرقتين فقط بدون الدشداشة.
يصير شلون يصير؟
with a big cheese. أهلا دكتور.
منو بعد؟ وليد كان ويانا. منو بعد يقدر يفتح الكاميرا حتى اوكي دكتور عادل ويا الخضراء والوجه الحسن. اوكي، منو بعد؟ وليد وبروفيسور رائد.
دكتور فراس لو تتقدم على الكاميرا بعيد.
سناخذ بس سكرين شوت والله وحدة تلوخ بس شوية وياها ابتسامة. اي that's fine. اوكي شكرا.
ما أعرف إذا أقدر أسأل سؤالي.
يعني in conclusion عمر، يعني أول شيء نشكرك شكرا جزيلا، ولا الختام للأستاذة. بس أريد أسوي conclusion إنه إحنا الآن الدرافت اللي سواه أستاذ فراس راح ينبعث لحضرتك حتى تعطي آراء عليه. نطلب من الأخوان زملائنا أعضاء المجلس يعيدون الرؤية أو القراءة للمقترح مال الأستاذ فراس والأستاذ عبد العظيم أيضا، لأن هذا الموضوع we have to finalize it as early as possible as a documentation. احنا عندنا طونا 10 ملاحظات الوفمي من راحوا، واحدة من عندها هذه دكتور عمر، ولذلك احنا نشتغل بجد انه to fill the gaps اللي هم بالحقيقة خلوهن واحنا مقبلين على report again للوفمي. يعني حصير 1 year since their visit، هم اجونا بنوفمبر. فاحنا we are planning to have a new report for them and to يعني to apply what have been achieved according to their requirement. فالختام لك أستاذة.
شكرا دكتور هلال. بس قبل ما نختم دكتورة سوزان عندها سؤال.
ما رفعت ايديها ذاك، احنا ما عبرنا تسأل.
لا رفع، هاي مشكلة ما رفع الإيد، إذا ترفع ما تنزل من. السلام عليكم.
عليكم السلام.
إن شاء الله دائما مرفوعة.
أسفة جدا دكتور عمر، شرفتنا حضرتك والله، كان كلش ممتع البرزنتيشن من حضرتك. أنا سوزان من أربيل، بس حبيت أسأل سؤال إذا ما أعرف جماعتنا من يشاركوني به. بالنسبة للفيدباك أعتقد الكليات معظمها they have يعني deficiency in that، يعني اللي هسه ما يعرفون شلون يسوون الفيدباك. فأنا ما أعرف إذا حضراتكم تقبلون مقترحي إنه نسوي لهم فد جايد لاين، نقول لهم بالضبط إنه الطريقة الجمع مال كل ستاندرد شلون راح يكون، ومنو اللي راح included in those feedback، مثلا stakeholder، student only، staff only، staff، patient، include all those together. يعني أنا أعتقد أحد الأشياء المهمة جدا بالنسبة للquality improvement هو الفيدباك. فإذا طريق مثل ما الدكتور عمر تفضل وشرحه، إذا الفيدباك ما عرفنا شلون نسوي، يعني هذه عانية خلال من سوينا الساس ريبورت مالنا. يعني أعتقد معظم الكليات عندهم هاي deficiency بيها، بس هذا كان عندي. إذا يعني هذا النقطة لاحظتها بكلياتنا. شكرا جزيلا.
مهم هذا يعني standard SOP policy and practice.
اوكي، يعني بس همنا للتوضيح واسمع اراء البقيه. يعني الفيدباك اللي هو اللي نسويه بالساس غير الفيدباك اللي بدنا نحكي عنه بالكواليتي امبروفمنت. الفيدباك اللي بالساس موجه كرأي للميديكال education curriculums assessment whatever. هذا الفيدباك اللي راح ناخذه فيدباك فيما يخص عملية الأكريديتيشن، فيما يخص عمل المجلس. يعني يختلف كل واحد إلى فد سبيكترم خاص. ومع هذا دكتورة سوزان وبقية الأعضاء المجلس، احنا يعني حكيناها سابقا الإيفيدنس جنريشن بوكليت، يا ريت تنطونا رأيكم به حتى هم نسوي له أبديت كل واحد الأريا مالته. إذا أكو أي توضيح نوضح بعد أكثر مثل ما وضحنا بالجايد لاين، ضفنا تقريبا 20 صفحة. هذا الإيفيدنس جنريشن أيضا ممكن إحنا نوضحها أكثر. إذا أكو أي بيج أريا بيج ستيتمنت أو إذا أكو أي شيء ما واضح به نوضحها.
يعني مع بعضهم
كل واحد يشتغل في الأريا ونسوي فد سياسة إن شاء الله، وكل من يشتغل بالأريا مالته حتى نطور البوكليت هذا. دكتورة آمال بليز.
شكرا أستاذة يسرى. أستاذة يسرى، حضرتك تفضلتي بالفيدباك رح يختلف. الفيدباك مرات إحنا نريده من الطالب، ومرات إحنا علينا أن ننطيه للطالب. فإحنا ننطي فيدباك للطالب اللي هو تقييم للأداء مالته، تقييم أداء الطالب، ننقل له إياه من خلال الكلام على أن يكون مقتصر على الأداء، ما يتناول شخصه أبداً. والهدف منه وطبعاً الطرق هم يعني تعرفوها ما راح نحكي عنها. الهدف من الفيدباك اللي ننطيه للطالب عن أدائه هو تحسين الأداء. هذا الغرض منه، ننطيه الأشياء اللي سواها صح حتى يعرف هذه صح، وننطيه الأشياء اللي تحتاج تطوير حتى يطور نفسه. هذا لتحسين أدائه. إحنا ناخذ فيدباك من الطلاب أو من الستيك هولدرز مثل ما تفضل الدكتورة سوزان. الهدف هو هم نطور عملنا. فشون نسوي فيدباك راح يعتمد على الهدف، على الاتجاه مال الفيدباك، منو يريده من منو. فحسب الهدف ممكن نخلي صيغة، أو إذا كان من عندنا يعني إحنا نريد من الطلاب أو من الستيك هولدرز، فإحنا دا نسوي كويستشنيرز ودا ننطيها. فحسب أهدافنا شو نريد نعرف، نخلي عنها أسئلة باستبانة معينة ونوزعها للمستهدفين من العملية. وشكرا.
شكرا دكتورة آمال. نعم، يعني هذا نوضحها بالبوكلت إن شاء الله إذا عدنا نسوي له أبديت. وعمنا يعني نخصص له وقت يجوز شهرين مثلا حتى نكمل هذا التوضيح. شكرا جزيلا للجميع. بعد ما أكو أي ملاحظات أي سؤال نختم إن شاء الله. ونشكر دكتور عمر وشكرا لجهودك ولوقتك، ويعني تسمح لنا يكون أكو لقاءات مستقبلا، لأنه العمل راح ياخذ يعني راح يتوسع ونحتاج إلى مناقشات أكثر إن شاء الله. شكرا جزيلا.
شكرا وتحياتنا للأستاذ
جزيلا.
عمر والأستاذ غانم.
شكرا جزيلا.
شكرا جزيلا. هلا بيك. هلا.
شكرا. عاشت الأيادي.
هلا بيك.
شكرا.
مع السلامة.
السلام.
احنا بنروح
نعم بس هذا هو
يعني روحوا انتوا هم ترحون.
وين نروح؟ قولوا لنا.
للبصرة للبصرة.
شكرا جزيلا.
لا حار، لا
مع السلامة.
يلا مع السلامة.
مع السلامة.
أشوفكم
مع
بخير إن
السلامة.
شاء الله.